Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Hello everyone, welcome back to the Research Works podcast. We're so excited to have you join us again.
Yes, thank you for joining us once again. It's good, we love it.
We do love it, and we are really excited for the episode today. I think a really thought-provoking topic and conversation that we're about to have.
Yes.
So we would like to welcome Jenny Lewis from the Children's Hospital at Westmead in New South Wales, Australia to join us. Welcome, Jenny.
Hi, Jenny.
Hi, how are you?
Very well. Thank you for joining us.
Yeah, we're so excited to have you on.
Pleasure to be here.
Well, we're really grateful for your time today, Jenny, and we'd like to share with our listeners a little bit about you and the work that you do before we get into our conversation today. So, Jenny is a senior physiotherapist in the Cerebral Palsy and Movement Disorders Service at the Children's Hospital at Westmead. Jenny's caseload includes assessment and intervention planning for children with cerebral palsy, in close liaison with primary treating therapists. Jenny works in the botulinum toxin, selective dorsal rhizotomy and intrathecal baclofen programs and neuromodulation program, which is a combined neurology and rehabilitation service, including deep brain stimulation and medication trials. She's currently enrolled in a PhD in research at the University of Sydney. Lots to keep you busy there, Jenny.
Very, very busy. Yeah.
We love
keeps me out of trouble.
That's the right attitude. I like that.
So, Jenny, that's the very formal getting to know you part of the podcast, but we also like to balance that out with a bit of informal getting to know you, and we do that with our icebreaker question. So our icebreaker question for today is, if you could be a character in a movie, what character and what movie would it be?
So I find this question, I hate icebreaker questions, but I think I would like to be Wendy in Peter Pan, because she was always off on adventure and going off into Neverland and just having fun and adventure and coming back, and
I love that.
That's what I would like to be.
Yeah, that's a good one because it involves flying as well. I think if you can fly, because you can't do that in real life, right?
You can be whatever you want if you're a character in a movie.
Yeah, anything is possible. Yeah. Well, as soon as you said it, the first thing that came to mind was Neo from The Matrix.
Oh, okay.
Because I think it'd be cool, like, to be able to see the world in that kind of way and to, like, dodge things and, like, do all sorts of wacky kind of things. But then and I thought that's a little bit too out there. You kind of live in the computer world. So I have a secondary one, which would be Indiana Jones and Going on Great Adventures.
Yes.
So I do think that would be really, really cool.
That would be really cool.
Right?
Yeah.
And like to have that, you know, that whippy thing and, you know, it's just
You're really embracing the
adventure
side of it.
Definitely
I love
the
that.
adventure.
Yeah.
That's my take. What about you?
Okay, well, this says a lot about me, but my first thought was I'd quite like to be Willy Wonka and have a chocolate factory. But
that is a well thought through plan.
Yes, but and I feel like I always have more than one answer to these, so it's not very fair. But I have 3 daughters, and I think I would have to lock in my final answer as being Elsa from Frozen.
Oh,
because if I did that, they would just think I was the coolest person ever
all
with
the
magical
friends would
powers.
come over, they'd all be there. Yep.
All the dress-ups.
Yeah, that's a really good one. Oh, so I like everyone's answers. Yeah, that's good. All right, well, let's get into what we're going to be talking about today. So let me give you a bit of a rundown of all the context. So selective dorsal rhizotomies are often spoken about in clinical practice. It is a surgical procedure that may be offered to children with cerebral palsy to provide more long-term spasticity reduction. There is often discussion around who's the most appropriate for the surgery, as well as the outcomes that one might expect. So the Australian Selective Dorsal Rhizotomy Registry houses rich data sets as an ongoing multi-centre national research registry, including 5 tertiary paediatric hospitals in Australia, providing clinically relevant information for clinicians, researchers, and, of course, children and their families.
Thanks, Dana.
Very welcome.
And selective dorsal rhizotomy is not something that we've spoken about, I think, explicitly on the podcast at all to date, Jenny. So for our listeners, perhaps for those who, might be familiar with the name but not necessarily familiar with the procedure, could you just talk us through what that involves in a little bit more detail?
So as Dana mentioned, it is a neurosurgical intervention, so it's a surgery on the spine, and it permanently reduces spasticity in the lower limbs. It's suitable and can be effective treatment option for children who've got bilateral spastic cerebral palsy, who have goals around improving their functional mobility or their walking. And there is a selection process around the kids who are suitable for it. So we have in Australia, we probably follow quite a conservative selection process. But it's because we look at the evidence around who it is suitable for. So which type of child's going to benefit from SDR.
Yeah. And what kind of things are involved in the selection process? Like you just alluded to the fact that it's maybe different in different countries, but here in Australia, what does that look like?
So when we're looking at a child who might be suitable, there's certain characteristics or clinical features that we look for that can help determine. So evidence tells us that the children who are get the most benefit or mostly suited for SDR are kids who have the diagnosis of cerebral palsy. Spasticity is their predominant motor type. So some children have mixed motor types, so they might have dystonia and spasticity. We know that it works well on the spasticity, but not on the dystonia because of the pathophysiology involved. Often it's for kids who are PREM. So PREM who on their MRI have periventricular leukomalacia. So these are all the things that we sort of consider as we're going through the process of looking at what's going to be suitable. So children who are at a stage of walking or walking independently or using some sort of a walking frame or sticks, crutches. They're strong, so have some good underlying strength and selective motor control. So you're able to get good results from the intensive rehab that's involved. And also be able to be motivated. So really be the child as well as the family motivated to follow through with the intensity of the program. Because it's, as I said, it's quite an intense therapy that can go on for 12 to 24 months.
Wow,
so they're all the sorts of things that we consider in discussing with families what we look for in a child where SDR is a treatment option because it's permanent. Once it's done, there's no going back. So it's something that needs to be considered. Carefully.
Yes, definitely.
Can I ask a question around that selection criteria? Like there's quite a few things that we know about measuring. So spasticity, you've got modified Ashworth of the ASAS, strength, I imagine, manual muscle testing or handheld dynamometry. But for selective motor control and even motivation, are there any outcome measures or is there subjectivity associated with that? Like how is that assessed as a team? Because I know those things are a little bit more, they're difficult to sort of quantify, or they can be, can't they?
So I suppose with selective motor control, we do use an assessment called the scale, which is looking at selective control of the lower extremities. So, and we find that this is, a pretty good standardised assessment. Children often have a lot of spasticity, especially around the ankles, so it's hard to actually see what their selective motor control is there. So, but we can get a good idea of their selective motor control around, higher up around the knees and the hips. So as long as they've got some good anti-gravity muscle strength to actually hold themselves up, that's what we consider, high kneeling. So we look at functional assessment as well. So things, and that's around strength and selectivity too.
Yeah.
Because, the children who are suitable are young children.
Yes.
So often it's quite hard to measure muscle strength and selectivity in the kids who are, the age groups that we tend to do is 4 to 8 years. So, it can be tricky measuring those sorts of things. So we look at functional measures as well.
And, before you even get to the point where, if a child is eligible and the family is going to take that up as an option, there's obviously lots of conversation and thinking that happens prior to that. How much time do you take, as a therapist to kind of manage and nurture those conversations with families before they make this decision? Because it is, as you said, it's a permanent decision, it's a big decision. So how do you kind of help families navigate that?
Yeah, so it is a long process. So the work up to SDR is quite a long process. We do get social workers involved to actually talk to families about expectations. We also speak to the community therapists to see how engaged the family is with their therapy, how the child goes in therapy. And I think, we're a lot more aware of goals around SDR and looking at the family's goals, what they're wanting to achieve through SDR and whether this is realistic. And, we're not expecting a child to go from, using a walker for very small distances to being able to walk alone without using anything. So it's all around that discussion about goals, expectations, and whether it's going to fit in with the treatment plan for the child. So there is a lot of we do a lot of discussion, and if we're unsure of a family, we'll make sure that social work clin site can actually get involved as well, just to nut things out to make sure that everyone's on the same page.
Yes. Yeah. There's quite a workup, isn't it? And I've certainly been involved in that process, and that's how I first met you, Jenny, is here in Western Australia, our children who would be considered for SDR would most likely go over to see you, and there's this whole workup that's done as a team. I am curious about the cases that I do often hear about. When I say often, it's every now and then, because it's not like SDRs are done all the time.
No.
But people that travel to different parts of the world, like whilst we have it available in Australia, there's still people that do travel to different countries for the procedure to be done, and they come back to Australia for some rehab, for example, and that's how I might meet them. Can you talk us through what that sort of involves and what's your experience with that? Because there is this element of travel then tells me a little bit about, the workup that's often done here in Australia, which is really comprehensive. Is that happening in other sites? Do you know much about what that looks like?
Well, I suppose it doesn't happen at other sites. Well, there's one overseas site in particular which will look at videos and things. So it's a very short workup, I think.
Okay.
I think it doesn't happen. I don't think it happens as much now. I don't think there is as many families who are going overseas. I think in the early days, there wasn't a lot of information out there around SDR being done in Australia. So families weren't sure where to look. We don't have much information on the internet, and families do use the internet a lot. Some families talk to other families in, therapy waiting rooms and find out that they've gone over to, say, America or somewhere overseas to have their SDR. So they're finding out that way about it. So I think, and obviously it's more established overseas than, it's especially in America, SDR has been done for a longer period of time than what we have been doing it here. So it may be, families' perceptions of, the more surgeries you've done, of course,
yes.
I don't know. But I think there's still a lot of misinformation about, that is out there through social media about where to go but as I said, I don't think it's happening as much now that we're sort of providing or starting to get more Australians specific information about SDR.
Sure.
So SDR's here in Australia.
And what would the really specific do you have any ideas of the misinformation? What's the most common piece of misinformation is out there about SDR?
I think they always give the positive side of things. So the things that you see on social media are kids who have had fantastic outcomes. I don't think they necessarily show you that, people don't share where SDR hasn't been helpful. So, some families might see it as a bit of a miracle. You take away the spasticity, so everything will be fine, because often, that's what they see as being the major component of cerebral palsy. But in reality, it's just one component of the overall picture. So, so I think, families do see only positive case scenarios. So
sure.
That's my impression anyhow.
And Jenny, you can obviously speak to your own experience here, but do you find that it's something that parents come to you asking questions about, or is it something that you talked about between 4 and 8 ideally is when a procedure like this would happen? So for the children that you think might be suitable, is it something that you preempt and start to have conversations about earlier on? Like, how does that generally work?
So it's really been interesting in the work that I'm doing at the moment with knowledge translation. So we've developed a decision aid, but in part of that process, we did a lot of qualitative interviews. So we did some focus groups and interviews. And families are wanting to know early on what the treatment options are. And I think probably, in previous years, we didn't really talk much about SDR until we'd gone through a process of seeing, trying trying Botox, looking at oral medications, and not necessarily giving information about SDR, especially if we didn't think it appropriate. But I think families want to know the information so that they can ask the questions and be part of that discussion, so that they know that we're not keeping anything away from them. So we need to be transparent in the information that we give, and we also need to make sure that it's all evidence-based. So yes, families want to know. Some families want to know sooner rather than later. And I think that's, you will discuss that from a clinician family perspective and get an idea of when families are ready to talk about more permanent options. But obviously we want them to try other less invasive treatment options before heading straight to an SDR. So it's that giving the information there, so not hiding it, and having it there as an option further down the track. So really thinking about treatment plans from year to year, basically. So
it's so important,
put it all
isn't
out there.
And I would say even my journey as a therapist and understanding the role of these kinds of interventions, I would say the bit of a misinformation for me back in the day of not understanding the evidence before I'd having looked at it was that SDR was, for some reason, seen as just like the one surgical intervention they might need to have. Yet what's really evolved is what was presented at Oz ACVDM with some of your colleagues as well was that there's often other surgeries associated. So it doesn't mean that you're not going to have orthopedic surgery for hips. And the numbers for that, I know you've presented that before, but it's not saying that if you have SDR, you don't need to have anything else. And that's a bit of miscommunication or misinformation as well, isn't it? Can you talk us more about this sort of intervention type?
Yeah, so we have looked at orthopedic surgery. So we've looked at different as part of the registry, we've actually looked at orthopedic surgery needed after SDR.
Yes.
And also Botox. So what we found with the orthopedic surgeries, and this is only on our Australian So children who've had their surgery, their SDR done in Australia.
Yeah.
So, and only looking at kids who are GMFCS levels 2 and 3. So what we found was that almost a half of our cohort needed to have some sort of orthopaedic surgery. So the children who were GMFCS level 2, they needed less surgery, so about a third of those went on to have surgery, and the surgery happened within that first 5 years after SDR, and, you know, on average around the 3 years post-SDR. So there was about a third had surgery, GMFCS level 2, and about almost 2/3 of the GMFCS level 3 went on to have orthopaedic surgery.
Yeah.
So it is quite a high percentage, and when we do talk to families, we do say, you know, it's highly likely that they're going to need some sort of orthopaedic intervention further down the track.
Yeah. And is that mostly bone, is it a particular type? Like is it related to, VDROs with hips, or is it more sort of soft tissue lengthening, a combination? Like, is there anything in particular that stands out?
Yeah, so it's a combination. Okay. So with the GMFCS level 2 children, it's more around function.
Okay.
So it's more around foot stabilisation surgery and calf lengthenings.
Yeah. Right.
For our children with who are GMFCS 3, you also additionally add hip surgery. So you're looking at femoral osteotomies and but it's usually it's mainly around hip and feet basically.
Okay.
And around that stability.
Yes.
In their walking.
Yeah.
We haven't looked at any of the 4s, but most of the surgeries, or most of the children in our database are GMFCS levels 2s and 3s.
Yeah. That's such useful information, isn't it? As you're looking, and like you said, if families want to know about SDR earlier on, forward planning is to make sure this is in the mix of that conversation, isn't it?
Yeah, definitely. And I think having the registries has been invaluable in actually letting us look at our numbers. I mean, it's national, so all of the states in Australia are collecting that information.
Yes.
But it's relevant for families. You know, we're all doing. We all have the same sort of clinical practices, and it's relevant. So it's been really helpful.
Well, I think that leads us beautifully into the Australian Selective Dorsal Rhizotomy Registry.
Yes.
So, you've given us a bit of a taster there about what it is, but can you tell us and the listeners about what kind of data and information this registry holds? How many children do you have included, and what kinds of information does the registry have?
So we've been collecting data, so both retrospective data, so from surgeries back in 2003 right up to now.
Great.
So both retrospective and prospective. So we collect it from children who've had, so they're all Australian children who've had surgeries done in Australia. Plus we also try and capture those who have had it done overseas. And it all goes into our registry. So families consent. We look at multi-dimensional outcomes. So we look at outcomes across all of the ICF. So we look at, you've got your demographics, so the age of the child at the surgery, gender, their predominant motor types, whether they've got any other movement problems such as dystonia. This is all recorded. Then we look at all of the different domains. So in the activity domain of the ICF, we're looking at gross motor function. So we've got various standardised assessments around that. We do GMFM, 6-minute walk test looking at endurance, timed up and go, as well as their functional mobility scale. So that would cover our activity level. We also collect information about pain. the goals. So we do goals. We set goals, look at individualised goals at baseline and look at performance and satisfaction on those goals at 1 and 2 years post. We look at spasticity measures. So as you were saying before, modified Ashworth and the ASAS. What have I missed? We look at the surgery. So we, because some families are going overseas, we want to make sure that we're recording the surgical procedure, the amount of rootlets that are cut, and then if there's any surgical complications. As we mentioned, looking at ortho, so the interventions that are happening before SDR and then after, so things like Botox and orthopaedic surgeries. It's a massive,
it's incredible.
It's a big registry. And then also we're recording, if there's any adverse events. So we do record, we look at spine X-rays and hip X-rays and feet, bowel and bladder. If there's any problems with bowel and bladder and sensation. So it's a big registry with all covering all across all the domains of the ICF, I suppose. And it looks at it at baseline, so before surgery. 3D. We also look at gait analysis as well. I knew I'd forget something.
I was going to ask you about gait. That's perfect. Good. I'll talk more about that. Out of all of them, you just missed one. That was actually pretty cool.
I think I've got them all. And it's baseline 1, 2, 5 and 10 years post. So looking at long term.
Incredible. Wow. And we mentioned it, I think, in the abstract, but just to highlight again here, this is across 5 tertiary paediatric centres in Australia, isn't it?
Yeah, that's correct. So we all, we're a really good group of clinicians. We've been working together for a long time and everyone's great in working towards making the registry work. So, which is fantastic. And at the moment we've got 100 last time I looked it was 107 kids who are in the registry. So, which is good.
Comprehensive.
Yeah. And we've often been talking about that. There's so many different kinds of study designs and there's such an importance and a role of registries because you can collate really information that is actually already been implemented. It's clinical practice. It's learning from ourselves in that kind of way. And I love that there's also adverse events too, because it's not just about how effective something is, it's in comparison to potential adverse events which would lead to the selection criteria for the future or things you need to look at.
And inform those conversations with families,
that's right.
In the future.
That's right.
It's really informed. I love that.
Definitely.
So not to start on adverse events, only because I was talking about just then, it's probably worthwhile talking about what sort of things that we are looking out for, which probably is the reason why there is a very clear selection criteria for children for this intervention. But what are some of the adverse events that you'd be really looking out for? You kind of mentioned bowel and bladder potentially too. What else do we sort of really want to keep an eye on?
Well, we want to keep an eye on spine. So it's a spinal surgery. So we want to make sure that, we keep an eye on it longitudinally. We don't have good spine surveillance at the moment for CP. So it's really hard to see whether it's natural history or whether it's as a result of the SDR. Sure. But we want to make sure, there has been, in the literature, it's been reported that it can be associated with scoliosis or lumbar lordosis. So we just need to make sure that we monitor this. And then, eventually when we do have more of an idea of natural history of spine, then we might be able to, do a comparison.
Yeah, sure.
So that is one area that we definitely keep an eye on. We haven't had any problems with bladder and bowel complications, and it's difficult to actually measure a baseline for sensation for children as young as this.
Yeah.
So really in the registry, it's more or less just saying, is there any reported, problems? Because we can't really get a good no standardised measure of sensation for children as young as 4. all.
Okay. Yeah.
Yeah.
I'm really curious about some of the outcome measures, and I did sit in on some of the presentations. And the GMFM result is always a really interesting one because it is, yes, it's our gold standard assessment over time, and it can capture some really rich data. And I know that you guys presented about that. So can you talk us through some of those GMFM results?
Yeah, so Olivia Lee, one of the rehab specialists down in Melbourne, she actually presented on that at the recent conference.
Yeah.
And with the GMFM, when we analysed it, we looked at whether it improved across up until 5 years post. So she was looking at the time frame between baseline and 5 years after SDR. And we also compared it to natural history. So looking at the GMFCS levels, the GMFCS curves and the natural history.
Yeah.
And we found that the children who'd had SDR really tracked nicely along the GMFCS level curves. They improved significantly, but they also, and in particular GMFCS level 3 children, actually went above their natural history curve. So I suppose the main thing that we got out of that was that no children were worse off. They actually are following their trajectory, which is great. And I mean, this was up to 5 years post.
Yeah.
Well, this is that group of kids, you know, that lovely Hannah graph where you've got the GMFCS level curves between 7 and 9. That's where you start to see a bit of a dip for GMFCS level 3. So that's kind of bang on when it comes to the time. It's actually quite a significant result.
Yes, yeah. No, the kids, they have done well in their gross motor function measure.
Yeah.
And Jenny, you know, just going back to what we were talking about before around commitments post surgery, we talked about, you know, sometimes often there is a need for additional orthopedic surgeries post SDR. But you alluded to, I suppose, the therapeutic commitment for families post SDR. Can we just talk a little bit more about that? And because, you know, obviously that plays a role in those results that you see in terms of gross motor function. What does that look like for families?
So they stay in hospital. So depending if it's a multi-level procedure or a single-level procedure, will depend. That will sort of guide as to how long they're an inpatient. But regardless of which, whether it's multi-level or single-level, for the first 4 to 6 weeks, they have intensive rehab. So they have day rehab every day, twice a day for the first 4 to 6 weeks. And at the hospital, so they either need to be staying at the hospital or very close by so that they can continue to participate in that sort of regime. Some of it is hydrotherapy, so they'll start doing hydrotherapy as well as land-based therapy. And besides the therapy sessions, families are also doing some sort of like they have an exercise program or a home program that they will do. And this could involve positioning or some exercises on the bed or however that may look. And then after that first 6 weeks, then they go out into the community. So we need to make sure that they have funding in their NDIS plan, and they've got community therapists on board because they have physio 2 to 3 times a week. And that is for the first 6 to 12 months.
Wow.
So depending on how the child goes and how their progress goes, it is a big commitment.
Yeah.
And families will say to us that, you know, you get out what you put in. So they really emphasise the need for families, future families, to know that it is a big commitment, but it's well worth it in the end. Like, you know, they all said that, you know, you need a village to help after an SDR, but they did see the importance of the intensity of the rehab. After that first 12 months, then you can really look at integrating some more community activities. So you've got your bike riding and swimming and things like that. And the way in which your physio or your therapist might their model might be more around block therapy, but you still need to have a close relationship with your therapy team.
Yeah. And as you're describing all of that, I'm just thinking about the huge amount of coordination that is involved in, working up to an SDR, but then also, you talked about making sure your NDIS plan matches up to, what you're going to need in terms of therapy post-SDR. And it's just huge, the level of coordination and the number of people that have to be involved to really, make this a positive outcome for families.
Well, on that raises a really important point that I've been really percolating about. So the advantage of something like an SDR is that there's coordinated care that's really led by the team that you would lead, Jenny, and your whole team. The pre-op workup, what happens post-op, the kind of interventions they need to do for 6 to 12 months. And then beyond that, so making sure the NDIS plan also matches alongside that, bringing the community therapist around, and in a place where, choice and control of what interventions you want to have, coordinated care can be really hard to come by. But by having SDR, there's almost this structure of therapy that needs to be provided at a time where we know you could start to sort of slip a little bit in function. How do you, and it might not even be possible, like how can you tell the difference between what is coordinated, really good level of care at quite high intensity for so long versus what the spasticity reduction has done from an SDR perspective? Like, is there a way that we can tell? Because it's obviously a lot of intervention as well. We know that we can make improvements in GMFM. So I love SDR, so I'm not saying either one, but I'm just kind of like, how do you tell the difference between that, right? Like how can we decide?
I don't know. I mean, obviously, if you have that much intensity of therapy, regardless of SDR, you're going to get improvement. I think having a reduction in your spasticity might make your therapy interventions easier. So
more than what botulinum toxin might do if you had it frequently over that time. Like, as obviously botulinum toxin, it wears away after a little while, then you can go back again. But we think there might be something more enhanced about SDR just because it's that level playing field of spasticity reduction. I don't know, is that what you might think?
Yeah, I suppose the other thing too is that often the kids who we do see for SDR, Botox has gotten to a point where it's not as effective. Well, not that it's not as effective, but it only lasts for such a small period of time. So that is just, that is part of the mix. You sort of get a progression and then you go back and then you get a progression. So there's some research at the moment where they're comparing SDR versus non-SDR. There was a group in the US and they compared. So the ones non-SDR were going through their usual interventions as well as and they included the orthopedic intervention. And they found that the long-term outcomes are similar. So that's the other thing, you've got orthopedic intervention is another intervention. I suppose it just... I
wonder whether it's like in my mind, I sort of go down the path of energy expenditure, right? So if you reduce spasticity, the ease of which to do something requires less energy. And I wonder whether the impact on cognition and schooling and, not being tired every time you get to things, whether that's an outcome. But it's obviously captured beyond our motor assessments that you may not be able to appreciate those other impacts.
Yeah, you're almost, this is a very crude way of explaining it probably, but you're like freeing up capacity within the child.
That's right.
To be directed elsewhere. Yeah.
Are there measures on that at all, Jenny? Are we?
I don't know. Some families comment on mood as well.
Yeah.
So mood, discomfort.
Yes.
They may not necessarily isolate pain, but I think sometimes kids don't know they've got pain until they don't. Until they may not have the pain anymore. That was a comment from some of the focus groups that I did, which was interesting. But we don't capture that with our outcomes.
No, but I think certainly the the comprehensive nature of the registry that has been created means that you can start to ask some of these questions. And I think, it's such a powerful tool, both now and looking at kind of outcomes for the future.
Yes.
So Jenny kind of alluded to it a little bit there, but what's next for you in this work? I know, you're enrolled in a PhD. You talked about knowledge translation, which we always love hearing. So can you tell us a little bit more about the work that you're doing in that space?
Okay. So what I'm doing is looking at knowledge translation strategies around SDR. So from a clinician perspective, I realise that there's not a lot of information out there that's specific for the Australian population, and families are wanting to know more. So by using the registry to get that information, as well as evidence that's published, we're developing some more information resources for families and community clinicians. So we've developed a decision aid, an SDR decision aid, which gives information that's, in a easy, understandable format. It looks at risks and benefits, what SDR is. It talks about the selection process and just gives that basic information so that families can, after they've read it, they can think, well, I want to go and talk to my rehab team about this. So just to start the conversation around SDR.
Is that available already for
soon?
All of us?
Soon.
Soon? Okay, all right. We'll be in touch then. Yeah, okay. That's good.
And sorry, Jenny, is that a decision aid for families, or is there like a clinician version as well?
It's really for families.
Yeah.
Right.
It also provides information for community clinicians as well, with references and things.
Yeah.
But we decided just to do one. We've also almost finished with a couple of videos or films about pre and post journeys with 3 families with lived experience of SDR.
Yeah.
And, the information that we're getting through the registry is going to help guide us in the information and the education resources that we're providing or, co-designing with families.
That's wonderful.
In the future. And hopefully it will just help with that conversation as well as help with informing, in their decision-making around different treatment options. I mean, it'd be nice to have more information resources about all sorts of things, but SDR is just the place that I've started.
Yeah.
So.
Oh, you're the perfect person for the job, Jenny.
Important place to start, I think.
Yeah, that's right. Really, really good. Well, we'll watch this space. Keep us up to date about when this is available, and we'll definitely help to circulate it around too, because it's so important.
Yeah.
Look, before we wrap everything up, though, we're going to go to our final segment, which is the one where we'll see what kind of question he asked for today. So let's head into Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, fair comment. And he has been listening on this conversation. We don't ever prep him for this, so we don't know what's going to come out either. No. I hold my breath sometimes, but he always comes up with just a different perspective, and it's always a worthwhile conversation. So Jenny, before he launches into his question, I'll get you to summarise this area or what we've spoken about in about a minute or so. And then, Ed, you'll have time for one question. Go for it, Jenny.
Okay, so SDR, Selective Dorsal Rhizotomy, is an intervention that is a neurosurgical intervention that permanently reduces spasticity in the lower limbs. It can be a suitable option for a child with bilateral spastic cerebral palsy. Information from the registry is being collected, looking at long-term outcomes, and we're going to use that information to help guide our development of information resources for families. So hopefully it will enhance their knowledge about SDR, as well as help with discussions with their teams, their treating teams, whether it's the community team or their health hospital team, rehab team, about whether SDR is a suitable option or whether it's not. Hopefully it will give them that information.
Beautiful
That's
summary.
Great. Thank you. All right, Ed, ready for your one question?
Emphasis on one.
I like to ask many, Jenny, so I'm doing everyone a favour. Here we go.
Okay.
I will say that there's lots of multi-syllable words there that I was taking a long time to kind of absorb and try to make an intelligent question out of. I guess it's great hearing that these types of therapeutic interventions and options are available for families, and obviously new things kind of come along as the evidence and research grows. And given that the podcast is now reaching hundreds of thousands of downloads, we have a lot of our audience that is outside of Australia. And I guess my question would be in relation to things like opportunity costs, and I guess how that kind of weighs on the decision-making process, because I have a computer in front of me and I did a very quick Google search, and it appears as though SDR surgeries in the United States range from $30,000 to $50,000. That's including hospital stays. But I just wonder that with that sort of cost involved and how that kind of translates to the decision-making process. And I guess you've all kind of commented on that whole element of freeing capacity or easier ways for patients to be able to achieve the completion of their tasks or daily living activities after this type of an intervention. I'm just wondering whether there is a big issue there with the kind of recovery time that's involved, and then the financial cost that's involved, and maybe even things like emotional or psychological kind of effects that kind of happen over that recovery phase. I don't know if I'm asking something incredibly complex here, but I'm just wondering where that's kind of factored into the decision-making.
That's a good question, Ed.
Yeah, no, that's a very complex question. As far as costing goes, so America has a very different system, healthcare system,
Sure.
Which is very driven by sales, I suppose. Like here in Australia, SDR surgery is covered under Medicare, so there's no cost to the family. If they go overseas, they do need to privately fund it. But when they would come back from overseas, then they'd need to make sure that their NDIS plan is up to date and they've got the therapy needs and the funding within that plan. So I think in Australia, it's not a cost thing that is involved, so that's a good thing. So it's not driving or disadvantaging anybody,
Sure.
Which is really important. Now, the other question was around emotions. So was that right? Emotions,
just the other costs that I guess that are affected in or taken into account over the recovery terms, recovery phase of post-SDR.
Yeah. Obviously, a family who's got supports around them, that's really important, and that's come across when you speak to other families, or to the families that we know whose child has had SDR. So it needs to have people around you to support you. Yeah. So does that make it difficult for some people? Possibly. I suppose that's all part of the discussion about whether it's going to be the right thing, or not for a child.
Right from the beginning, hey,
yeah. So,
and who else they can be linked to as part of that recovery?
Yeah, and knowing that they've got the right supports around them. So whether they need to have more support around social work or getting more involvement into looking at funding options to help them in that in that respect, whether the child needs to have more clin-psych input before the surgery.
Yeah.
And then, obviously after the surgery. And we hope to develop some more child-specific resources as well. So to hopefully help
part
with
of
that.
the big job there.
I know. It's,
Well, it's a very
that was a great question.
But he led right through to the
Always
end.
does. Yeah.
I know.
Well, Jenny,
dear.
thank you so much for joining us on the podcast today. And we look forward to these resources, and please do share it with us, and we'll make sure to pop it on our website, researchworks.net, as a source of information. Remember, there's a CPD form there you can fill out as well to keep this as part of a record of your PD requirements. But for now, we must say thank you once again, Jenny.
Thank you, Jenny. Thanks for walking us through, such a complex topic. We appreciate your time.
Yeah, that's fine.
Yeah.
Thank you very much.
Thank you. And to all of our listeners, we'll talk to you all again really soon. Bye.
Bye.
Bye. See you. Bye.